Hello, everybody. Welcome to this Board of Directors meeting of Nottinghamshire Healthcare NHS Foundation Trust. My name's Paul Devlin and I'm the Trust Chair, and really pleased that you're able to be with us either live as we're broadcasting or perhaps watching us afterwards. And to start our meeting, as we always try to do, is we want to hear experiences of people who use our services and indeed from our staff providing services. And in Carers Week, I'm really pleased to welcome Neil Allen along. Neil is a carer and is supported by our family interventions team, and our colleague Laura Glackin is with us as well. And Neil, I'd really just like to invite you to tell us a little bit about your experience as a carer, please, just to help us frame our day today as a board of directors. So over to you.
Yeah. Okay, thank you. Yeah, my name's Neil Allen. I live in Nottingham. I originally come from Clifton. About 15 years ago, my mother tragically passed away of cancer, and she'd always looked after my sister, who has suffered with mental illness from a very early age. And one of the biggest journeys is, I might not get the terminology right, but you'll understand what I mean when I say this, is my experiences with the services. Because right from the word go, when I first got into the services, I didn't know who to contact, I didn't know where to go, I didn't know who to see. Everywhere I went, I felt like there was like these doors that I was trying to push open and nobody seemed to be listening to me. And I just felt very lonely. And little by little, I did start to get into the services, did start to be able to talk to people and saw psychiatrists and XYZ. But at the same time, it was really difficult because my sister, she was she was sectioned 13 times, I think. I can kind of say around about 13 times, it might be more, over the past 15 years. She's actually spent about 7 years of her life in hospital over, periods of months. And that was one of the biggest, oh my God, to go into a hospital where you've got a loved one. And I didn't get any information. Nobody speaks to you. It's almost like you're this alien that nobody wants to engage with, or and it's like, I thought to myself, if I was paying for this, somebody would be actually talking to me. And then all of a sudden I thought, well, actually, I am paying for this because I pay for it through my taxes and insurances. So why the hell am I not being treated like I'm being like I would be in a private situation? And ever since that day of first going into hospital, it has got better. I can't be too negative and say that nothing's changed, because things have changed and things have got better. But it's this communication thing. I've written things down so that I don't, lose track of what I'm saying. But, it's like this patient confidentiality, which I completely and utterly understand. And I know it has to be there. But patient confidentiality, I think, should be renamed as patient harm, because in certain circumstances, I know my sister really well. I know what she goes through. I see it day in and day out, and I feel it, and I can tell you, it gets me to a place where I feel like I need to be on tablets or XYZ. But sometimes it's like, as a carer, we know the person that we're caring for. We see them every day. We hear every day what they're telling us. And it's like, and I can tell you all that I have a wealth of information. That's what I'm trying to say. I have a wealth of information about my sister. And I never really believed that I'm ever listened to, even to this very day, apart from a person that I met recently, Tracy, to this carers group has made a difference to my life. And I'll tell you why. And that is because I've met people. I thought I was on my own. I thought I was the only person in the world that felt like this. I was the only person in the world that was having problems with the, with the services and how the services treated you. And lo and behold, I'm surrounded by all these people. I went to this first meeting. I was in tears. I was in tears because I was surrounded by people who actually were going through the same thing as me. It was like listening to the same stories that I was telling. And all of a sudden I thought, my God, I'm not on my own. And Tracy Thurland, who apparently works in the system, doesn't behave like anybody from the system. She actually behaves like she really cares. I don't feel like she's reading from a book or reading from a rules and regulations, and she talks to you like you're a human being and understands what you're going through. And even she really understands the fact that well, in my case, my sister. So it's like I have got, for the first time, I really felt like everything I know about my sister was valuable information. Because when you sit down in front of psychiatrists, and I'm not having a go at psychiatrists, but I go to these meetings with my sister and psychiatrists and CPNs and XYZ, and I come out there and I think, well, what was that all about? Where have we got? We haven't got anywhere. We just talked about the situation, didn't really get anywhere. And this morning, for instance, Dale Street, fantastic organisation, really brilliant at supporting my sister. There every day of the week. But this morning they ring me up. My sister is this morning in Queen's Medical Centre. If I get a little bit upset, please forgive me.
Sure.
She's in Queen's Medical Centre this morning. She's always wanting to take her own life. She goes through highs and lows. This morning she was found on Trent Bridge, apparently trying to throw herself into the River Trent. And a passerby happened to talk to her, got on the telephone, has gone and rung the police. The police have picked her up, taken her to Queen's Medical Centre, and she's in Queen's Medical Centre as we speak. And I don't know what's gone off. Nobody's telling me anything at the moment. I don't know what she was actually doing when the passerby saw her and contacted the police. I don't know how she was dressed. But she does this a lot. She does this a lot. This is what we call walkabout. She'll go on walkabout at like various times of the day or night, dressed inappropriately. I mean, she can be dressed in she's been out in just an overcoat with no clothes on underneath. You know, that's how bad it can be, and it's a dangerous situation. Because she's a vulnerable human being. I mean, to be honest, I could go on for hours, but yeah, I can see that 10 minutes is nearly up.
Let me pause you at that point, Neil, just before I open it up to colleagues, just to give you a couple of reflections from myself. First of all, I really appreciate that you're going to be wanting to be somewhere else as soon as possible to actually be finding out exactly what's happening with your sister right now, you've absolutely got all of our thoughts with you. But I think more important is to say thank you to you for sharing your experience so clearly for us. I have to say it's not an easy listen, but it's a really important listen for us. And I'm sitting here in my office. On the wall opposite me, I've got a note that I always have, which says, how will what I am doing today benefit our patients, their families and carers? And I think that you've just, for me, put a real challenge in there about, okay, so where is our commitment to carers as an organisation? And I know that we have teams like the Family Interventions team that Laura's part of that are working hard to help us improve on this. But I think what you've set out for us, Neil, is some real experience there that is saying that we have not, and indeed aren't always still getting this right for families, for carers, and absolutely for your loved one who is in receipt of our services. So what I'd like to do, if I can, is just to open it up for board colleagues, just to give questions, but also comments on. I think bluntly, there's a big so what there from what Neil said there. So actually, we need to think about and be able to be thinking about, well, what are we going to do having heard this story? Because that's a very powerful story. And as you described, Neil, whilst you'd felt like you were on your own, you're not. And that is an experience that is unfortunately replicated by many. I know that around this board table, there are a number of us who have been or are carers as well, which isn't, it's not to say that we will understand fully your experience, but some of that may chime for some. So Carolyn, if I can come to you first, please. Carolyn.
Thank you. Good morning, Neil, and
Morning.
thank you for your presentation there. Really heartfelt. Sorry, I'm Carolyn White. I'm one of the non-exec directors on the board here.
Right.
My question, Neil, is you've been involved with mental health services, obviously over a prolonged period of time now, in your care of your sisters. Do you think your experience is common of other family members looking after people within our system? So it's a kind of leading question, I think.
Yeah, well, I can answer that. You know, that's a really simple thing to answer because of joining the carers group. Because when I joined the carers group, I was surrounded by, I think, 12 people because of COVID at the time. And they were all kind of saying the same things, you know. I mean, they're all good. You know, there are some fantastic individuals within the service. I don't want to make it sound like it's totally dreadful, but they had the same experiences. That's what was so uplifting for me, that they had the same experiences, you know.
Okay,
so
I mean, that's really helpful, because I think that our challenge from listening to good people like yourselves who take the time to come and talk to the board is, as Paul said, what do we do differently? So it feels as though the issue of effective communication with our families of patients needs to be improved. And I wonder sometimes if we hide behind this banner of confidentiality too much. It's just an easy thing to throw in people's way, isn't it, rather than taking the time. So I haven't really got an answer for you at the moment, other than my commitment that as a board member here, we will take your story away and look at how we can do this differently with colleagues, because it is so important, because you are living with the reality of your sister's illness all of the time. And so we need to be able to help you to do that in the most effective way that you can. So thank you for sharing your story.
Thank you.
Thanks, Carolyn. I've got Nigel, and then Sue N, and then Sue E. Thank you, Nigel.
Hello, Neil. Nigel Smith. I'm also a non-executive director. I think it's a very brave thing for you to do to come on today, by the way, and I really appreciate your candour and your passion. I've heard this story, sadly, quite a few times down the years, different. So I think it is common, actually. I hear it mental health hearings, and I've heard it in other trusts that I've worked in. Obviously, the details are different, but the point you made about access, frustration, language, and not quite knowing where to go. I think it resonates with me. I've heard it a number of times over the years. My question for you is, given what you've said and the passion that you've got for this and the frustration that you've felt, is a simple one, really. Have you ever felt inclined to, or actually made a complaint?
Well, I have made complaints. My sister was, she was basically raped in the old Ivory Vale Hospital and I've kept all the correspondence from it because it was a mixed ward, and I made a complaint about that, and that was like over, I don't know, over 10 years ago. When no, it was 15 years ago. It was just before my mum died, actually, and I was told that they couldn't do anything about it, and I've kept all the correspondence. I can't remember the name of the guy who was at the top of the tree then. His name was Michael. He was the chair of the NHS. I can't remember his name, but it was Michael something. And I wrote to him, and I've got the letter that I received from him. And if I'd have complained in today's environment, something more would have been done about it. But yes, I have complained, and I haven't really got the response that I thought I should have got, which was pro the my sister's case rather than pro the NHS. It was like I felt like they were defending themselves rather than getting down to the actual seriousness of what had occurred. So that makes sense.
Okay, thank you, Neil. Thank you, Paul.
I think it's another piece for our. Okay, so how do we make use of that feedback? Sue Nixon, please.
Yes, thank you, Paul. Hello, Neil. I'm yet another non-exec director here at the Trust, and I empathise enormously with you, having been a carer for about 25 years. And I think there are a number of other people, and as other people have said, it's awful, isn't it, that others have experienced same issues and difficulties around a number of trusts, not just here at Nottingham. So thank you very much for coming. You answered one of my questions to my colleague Carolyn about communication being really, really important, and we will take that away and have a look at it. But could I ask you, as a carer, about your own situation in terms of how you look after yourself, having to deal with so many issues? Because the difficulty with carers is that people often forget it drains you enormously. And I just wondered what sort of support you needed to help you feel to keep on going. I hear you get a lot of strength from the support group, but is there anything else we should be thinking about to support our carers?
Well, I think, one of the major things that would really help me, and I don't know whether that would help other carers, is the truth. I'd rather people be truthful with me. If you can't do this, if I'm asking you to do something for my sister, instead of throwing red tape at me and blah, 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 just say, we haven't got the staff to do it. We can't do it because we haven't got the staff. I can cope with that. I can cope with the truth. And I know not everybody can cope with the truth, but I really can. I don't care how bad the truth is. It's just that I cope with that. I just tell me the truth. If you tell me the truth, I can go, great stuff. Now I know the situation, I can plan around it. And the other great thing I've got, my wife is a massive supporter. She's been involved years ago in psychology, and she's also a singing teacher, and you really have to be a psychologist to be a singing teacher, I can assure you. so she's, and I have massive support from her, which is integral. And the other thing is as well, the other great support for me is the fact that I get out on my bike and I do a lot of walking, because without some kind of physical exercise, it really lifts my spirits and makes me feel better.
Okay.
Great.
Neil,
Thanks.
thank you very much, and that very much chimes actually with the values of the Trust. So we will take away your points about being open and honest and truthful. Thank you.
If we go to Sue Elcock, and then John, I'll just invite you to do a bit of a wrap up as well, please. Sue.
Thanks, Paul. Hi, Neil. I'm Sue Elcock. I'm Medical Director and Forensic Director in the Trust. So I'm not one of the non-execs, because lots of my colleagues have spoken. But I just thought, when somebody asked you the question about is this common, I was jumping up and down in my seat, because it is common. I work with lots of carers across different areas, and obviously where I work primarily in terms of the school services, You know, there are tensions, but I think we're trained, if I'm honest with you, a lot of our training is about, I would say, a very black and white view of confidentiality. And what we're trying to do is to get into different situations to understand, because there's nothing that stops me as a psychiatrist, for example, listening to a carer, just because a patient perhaps might have said, you know, I don't want everything that's going on disclosing, etc. There's nuances to it that we're trying to work through, because what you're experiencing is, as you say, that sort of, sometimes it's a fearful response, because we're trained to say that we can solve everything. So to have to say, area, you're right, actually, we can't do that, or we can't solve it, goes against the grain. So it's a slow job, if I'm honest with you, but I think we're all trying to support that. And I think the other thing that I was just going to say was about complaints. When I talk to some of my colleagues about complaints, you're right about the level of defensiveness, because people are worried a lot of the time about litigation and things like that, which isn't right, but they're thinking about long-term consequences, not that person like you that's in front who's going to read that. So people that know me know I'm very attached to my mother, and I often use her in feedback to colleagues and say, if that was your mother that you're getting a response about, how would you feel? I'm not trying to say it's all sorted in any way, shape or form, because it's clearly not, but just some sort of things that we're starting to try. So thank you.
Thanks, Sue. I think it's helpful getting that different perspective, and as you say, absolutely not minimising what we've been hearing. John, can I just invite you to give a kind of a final comment, and then I'll wrap up if I can.
Yeah, morning everybody. John Bruin, Chief Executive. Neil, thank you very much indeed for taking the time to come and tell you and your family's story. I think it's probably touched all of us on the board. Your passionate commitment to doing the right thing, but also the candour in which you've told it, and given the situation you described this morning as well, just thank you for taking the time to come and talk to us. Part of my role will be to make sure that we don't just leave this sort of as a interesting conversation.
Yeah.
We've got to get some, so what are we going to do about it? And I know you said that there's lots of good things as well, but some of the things you described just aren't good enough, are they, in terms of being on the receiving end of us? And I haven't got a long list of therefore, right now we're going to do this, this and this, but there's some really important learning for us to take away. Sadly, this is a bit endemic in the NHS, and I think you described that really clearly at the start. You know, there's a sense that you get a different response in the independent or private sector. So it's something that we are aware of. I think the other thing that underlines, I mean, I was previously a psychiatrist too, that the devastating impact that long-term serious mental illness has, not just on patients but on families too, and the people that care for them. But we will take this away, both as a board but also as the executive team, and talk to Paul and Sanguinazzi and his team, and more broadly about how we can use this as an important learning for us to step up and improve the sorts of services and response that we give for broader families and carers too. So huge thank you from me for taking the time to speak to us this morning. I wish you and your family all the best for today particularly, but also in the longer term. Thank you.
Thank you.
Thanks, John. Neil, I hope that you're going away feeling at least that you have been heard on this occasion. You may well be wanting to then test that out in a few months' time to see what, if anything, has changed, which I think is a very valuable piece. But I think you've heard hopefully some very clear commitments from colleagues around the table. And I know that we are, through our Trust Carers Connect network, doing some focus around communication with carers this year, which I think very much chimes with what you've described to us.
Yeah, definitely.
So thank you again, and wish you well, and wish Julie well today, in particular. And in the meantime, colleagues, I think this is a really good reminder as we go through our board meeting that we keep patients, families and carers at the heart of our decision making as we go through, even on those items which at first glance might not look like they're about patients and carers. Let's go with them. So Neil, thank you for your time. Laura, thank you for supporting as well, and Amy and Paul, and really appreciate your time today.
Thank you.
Appreciated. Thank you. Okay, that's a really important start for us as a board today. So if we could go to our formal agenda, please, and just to say, in terms of the our welcome and introductions, just to say that we will be having a couple of colleagues shadowing executives. Kezia Foster and Tabitha Darman will be on our calls today as deputies shadowing executive directors, and we've had apologies from Fiona Daniel and Manjit Darby as well today. So if we could go, anybody got any declarations of interest for our public board today, please? I'll just pause, and if you could indicate if you've got anything. I haven't spotted any that look obvious to me. In which case, let's go to the minutes of our last meeting, if we can, please. And could you indicate, colleagues, if you're content that these are an accurate record of our last meeting? Just wait for those indications to come through. Thank you very much. And then if we could move to matters arising in the action log. The action log is there, and we have progressed those actions, I believe. So I just pause to see if anybody's got anything they want to pick up from the action log. I should have said, by the way, that we hadn't received any questions from the public for our meeting today. Sorry, I should have mentioned that. So let's move on, if we can, then to item 8, which is about the establishment of an integrated care system provider collaborative at scale. Jan, if you want to introduce yourself and this item, please, Jan.
Thank you. Morning. Jan Spencer, I'm the Executive Director of Partnerships and Strategy here at the Trust. There are a number of new partnerships and new structures coming into place at the beginning of July this year, with the new legislation having been enacted. Overall, we are moving into the integrated care system. The CCGs will be disappearing, and an integrated care board will be established for Nottingham and Nottinghamshire, covering health and care services across the county and the city. But also, as part of the establishment of new structures, we are being asked to collaborate far more as providers working across the system. And the idea that there are several provider collaboratives, and the Trust is involved in quite a few of these, but this one is specifically one to serve the population of Nottingham and Nottinghamshire. And it's called the Provider Collaborative at Scale, which means it's really looking at how do we work across services across the whole of the county. And particularly with the big NHS trusts, although I think in time we might want to consider how we also connect more with local authorities, with primary care, etc. But at the moment, the Provider Collaborative at Scale has been operating in shadow form for some time, and it consists of the 3 major trusts that are in the county and city of Nottingham University Hospitals, Sherwood Forest and ourselves. But because it was decided a few months ago that Bassett Law, which has been a separate CCG, will become part of the Nottinghamshire Integrated Care Board, and therefore come into the Nottinghamshire system. Bassett Law and Doncaster are also trust are also becoming members of the provider collaborative at scale, and also because of course ambulance services are central to all that we do. East Midlands Ambulance Service are also members. So up until now, the provider collaborative at scale has had as its lead chief executive our own John Bruin, who has chaired the meetings, and that was a really welcome move, because to some extent this trust occupies the space in between the two acutes, because we're providing the community services, the mental health services that kind of connect acute and other services, and also we're the one trust with a footprint across the whole of the city and county, which the other trusts don't necessarily have, and that served us well, and that's done a good job. Things are changing with the advent of the legislation, and in fact during the passing of the legislation a change was made. So there are now several positions that we need to decide who to represent us. On the one hand, we've got the Integrated Care Board that's being set up, as I said, across the whole of Nottingham and Nottinghamshire, and there are 2 seats for providers on that board. One to represent the acute sector and one to represent specifically mental health, which was one of the changes that was made as the legislation passed through the House, and very welcome from the point of view of the trust. But also we've still got the provider collaborative at scale, and we need to have a lead chief executive for that. Given that there are 3 major trusts that occupy the space in Nottingham and Nottinghamshire, and with the full agreement of Doncaster and Bassett Law and East Midlands Ambulance Service, what we're proposing is that therefore instead of John or his successor representing the trust on the provider collaborative scale as the lead chief exec, that we actually take up that seat at the Integrated Care Board, and that John and his successor are our representatives and representing specifically mental health on the Integrated Care Board. And similarly, that Paul Robinson, who's the chief executive of Sherwood Forest, does the same for the acute sector. People may be aware that Nottingham University Hospitals are also going through a change of chief executive. At the moment, they have an interim, Rupert Eggington. He will be replaced by Anthony May, who's currently chief exec of Nottinghamshire County Council, in the autumn. So what we've agreed in principle is that it would be good if Rupert and then Anthony, when he comes into post, takes over that lead role within the provider collaborative at scale. I should point out that the 2 seats on the Integrated Care Board are statutory seats. They are members of the board, and they have the full, if you like, voting rights of being on that board, which is a statutory board. The provider collaborative at scale does not yet have that formula structure, so the role there of a lead chief exec is not a statutory role. It's more of a convening and facilitating role. So actually the way the provider collaborative at scale is working is very much a collaboration, as you might expect, with all the trusts playing their part and all of us supplying resources and support to the way that we obviously need somebody who can convene and chair the meetings, and that would seem to be a good role for Nottingham University Hospitals. So the proposal in this paper is that the board agrees those nominations of Paul Robinson for Sherwood Forest, Chief Exec of Sherwood Forest, and John and then his successor as the representatives on the Integrated Care Board, and that we agree that Nottingham University Hospitals, first Rupert and then followed by Anthony, should play the role of lead chief exec within that provider collaborative at scale. And just to add, Paul, that the work of the provider collaborative at scale is ongoing. We've had workshops this week to try and hone down what are the key things that we think we can add value to patients in terms of our cooperation as providers. And whilst I can't at this stage tell you exactly where we've got to with that, there's still some further work to be done. I'm hoping by the time we have our next meeting that I can outline what we think those key priorities should be. And I just wanted to assure you that that idea of looking at it from the viewpoint of the patient is absolutely central. When we're looking at what are the problems that we need to solve, we need to think of them as what are the problems that patients would say, what are the problems that people are having accessing services, receiving good quality services, and really do it through that that viewpoint of the patient, in order to be able to get that very short list, because we can't change the world in 6 months, to get a very short list of the things that the providers can work together to try and improve.
Great.
That's the paper. Thank you, Paul.
Thanks, Jan. And just before I open it up to questions and comments, just to say that similar papers have gone to or are going to the boards of those other partner organisations too. So Paddy, please, let's come to you.
So Jan, that was very helpful, and it's a sensible way forward. I just wanted to pick up on the last point you were making, which is what the provider collaborative at scale is going to do. It's all very well to have the structure and framework for going forward, but it's actually the work that's important. So I guess the issue is how many things we want to take on, whether we want to look at clinical services or whether we want to look at back office and what the relationship is between them. I guess the other point is this is a bottom-up approach from the people who are in the collaborative. Where does the integrated care board fit into this? We could find ourselves doing opposite things if we aren't careful. Presumably you're on that.
Hopefully so, Paddy. Thank you. Really good question. So, and there has been some NED engagement, but there is some further non-executive director engagement planned as well. So hopefully you'll be able to be involved in that. So what we've identified is that we should have absolutely no more than 3 things that we focus on. Personally, I'd say 2, but we'll see what comes out. And that of those, at least one should be clinical and at least one should be an enabling function. And I think it's highly likely the enabling function will be something to do with workforce, because for all 3 trusts, that is our #1 risk. But not saying let's bite off the whole of workforce, that's a huge issue, but let's look at some really specific things that we can work together on. And we've kind of got a short list of things, and what we're asking is for Jen and her colleagues to narrow that down as to what are the things that we could really benefit by working more collaboratively on. In terms of clinical pathways, I think that is slightly more, I'd say even as tricky, if not more tricky, but it's almost to some extent less important which one we go for, more important to get one and really work at it and really prove that if we work together as providers we can do better. And so that's the stage we're at the moment. In terms of deciding those things, what we've already looked at is what is the integrated care system strategy, to make sure that everything fits and nests into that strategy. But also what we're now doing is looking at making sure that anything that we've got on our long list or short list isn't already something that duplicates something that's going on in place or something that's going on at the integrated care board. It's got to be something new and where we can add value. And we are being supported by some consultants working through this. We've had one workshop this week. There'll be another one later this month. And I hope, as I say, to report back to the board next month on where we've got to with that.
That's really helpful. Thank you.
Great. Stephen, let's go to you, please, Stephen.
Thank you, Chair. Not a question, just a comment. I have made the board aware previously of the fact that I am a designate non-executive member of the ICB board, and I have raised that in conflicts previously, Paul, but I think specifically against this item it's worth reiterating it.
Thanks, Stephen. Yeah, I think it's an interest rather than a conflict is the way I describe it at this stage, but it's an important one to make there. So Jan, you set this out really clearly for us, and there's a series of asks of us. So we're asked to approve the establishment of the Provider Leadership Board for the Provider Collaborative at Scale, to approve the proposed nominations for the partner member representatives on the Integrated Care Board, and to confirm the proposed leadership of the Provider Collaborative at Scale. I've not heard anything in comments that anybody's got any issues with anything that's presented in the paper with those recommendations. Let's just put that to colleagues, please. Are you content to approve all of those as set out by Jan, please? That's great. Thank you very much. So let's move on to item 9, and we're sticking with integrated care systems. John, I think you've got a brief verbal update on South Yorkshire and Bassetlaw.
Yeah, thank you. Hello again, everybody. This is just a very short verbal reminder more than anything that the vast majority of our conversations on integrated care systems will be based on the Nottinghamshire conurbation, but we are also a former member of the South Yorkshire ICS, by dint of having Wafford Hospital medium secure forensic services in that geography, and so we are formal members of the South Yorkshire group. In terms of their formal meetings, there was one due a couple of weeks ago, but it's been postponed, so we haven't got anything specific to bring today. Paul and myself largely cover those off at chief exec and chair level, and just to note really that we will bring regular updates as required to keep people briefed on things that are happening up in the north. That's probably as much I've got to say today, Paul. Thank you.
Great, thanks, John. I think absolutely right. It's about us making sure that we're explicit about our commitment to the South Yorkshire and Bassetlaw Integrated Care System 2, and from time to time we will include more information. So, colleagues, if I can move us on then to item 10, which is my report. I'll take it as read. One thing that's not really flagged there, but I know will come up later, which I did just want to take an opportunity to congratulate our forensic services around their excellent performance with the Care Quality Commission, the CQC, where there was a really good recognition of some superb improvement work that has been done by the teams there, that took the service from an inadequate rating to a good rating, which is a very big jump to make, actually. It's rare that services manage to do that, and really want to congratulate, and I know colleagues around the table would want to be associated with that as well, to congratulate the forensic services. I'll take the rest of the report as read and just pause to see if there's anything anybody wants to pick out from that. It does tend to be a bit of a summary of things that I've been doing rather than items for discussion, I know, but just pause for a second just in case. In which case, let's move on then, John, to the Chief Executive report, because I think you will then pick up some of the things in a bit more detail that I had flagged in my report. Over to you, John.
Yeah, thanks. Take the report as read, and I won't pull out too much really today. I'm happy to take questions and comments at the end, but to reiterate the CQC re-rating following the inspection of forensic services, tremendous all round, not just the services themselves, but all the enabling support services that supported those services from right across the organisation. And as you say, Paul, to leap 2 categories in one go is a phenomenal achievement. So fabulous news, and we've got our fingers crossed for the other reports as they come back. The CQC have indicated that we'll get them individually, so for each of the services that were inspected, and they're due imminently, so we'll obviously keep people appraised of those. On the second page, 25, Jan's covered off so the headline changes within the system, so I won't repeat that. In case anyone's forgotten about COVID-19, it's still out there. We've got one live outbreak at the moment, but pleasingly, you know, all the numbers are going in the right direction. People will have noted we've changed our advice on mask wearing in the last few weeks to enable those in non-clinical areas not to require them. The NHS is now on critical incident level 3, so it's all good news. There's that nagging doubt, isn't there, that's when you actually look at the stats, it's still out there, it's not gone away, and I'm sure there'll be more to hear about new variants, new requirements with regard to booster vaccines come the autumn, and again we'll keep people updated on that as we get to hear them. Just a couple of highlights. We had a fantastic, albeit very wet day at Hopewood, opening the Rainbow Road back in May. Great to meet staff, colleagues, great to meet service users, and we had a great couple of hours. Just hearing the joy that's on the surface, what can appear a very simple thing of getting that road painted in the rainbow flag, and it was a great achievement. Although hearing how long it's taken them to get it signed off was rather sobering. Again, something that will pick up internally to make it less of a trial for people. Fantastic International Nursing Day conference, and it was so good, wasn't it, to get back to live events and meet people face to face and have some of those really important conversations. Some brilliant speakers, both internal and external. Excuse me. And then part of our journey to net zero, some great showcasing of new menus at the Wells Road Centre, which our chefs and facilities team had collated from, again, across the trust, which was a great event and very expertly coordinated. And then finally, just in terms of operational matters, again, detail in the report, but just to flag that it's still tough, really tough in terms of service provision across all three of our divisions. Yes, on the surface, that some of the staff absences figures have improved, but just the huge volume in terms of demand, acuity of people needing our services in mental health, learning disability, forensic and community is huge, across a workforce that's really stretched, as we know, don't we, in terms of staffing levels, in terms of mental health and physical health of our workforce. It's not just this trust, it's right across the NHS and care services, but I put in the executive summary, it's a really important aspect that from a board perspective we've got to stay minded to, and not just think, like when we're not at work, that COVID's gone. The impact of COVID will be long term, and we want to make sure that we can support our staff colleagues across the whole organisation in what will continue to be really difficult circumstances. And then finally, Paul, there's an ever-increasing commentary on some of the things that we're engaged with through all our different services in the comms and engagement section, and some fantastic highlights of staff from across trust being nominated and being successful in all sorts of local and national awards, which is really heartening to see. And again, I'll leave it there. Happy to take questions. Thank you.
Great, thanks, John. And it's really good just to see the breadth of our services being represented so much in that report. I think for a good while we were understandably getting a bit uni-focused on the pandemic, and it's really helpful seeing that breadth coming through again. Paddy, let's start with you, Paddy.
So John, thanks for that. There's an awful lot in this. I was particularly interested in the top of page 27, the system-wide community transformation programme. This sounds like a really important, really innovative piece of work. I mean, could you just say a little bit more about how we're going to take the learning from that forward and widen out whatever we get from it?
Yeah, thanks, Paddy. I know I can see Becky has popped onto my screen, who's the expert and guru on all this, and has been leading. I think it's probably true to say, Becky, some tricky system conversations at the height of the pandemic too, and it's there's a huge transformation program in play, and my sort of commentary is that I think Becky will tell you more, that she's really stood by the phrase of transformation. It's truly transformational. It's very easy to use the term, and you don't see very much change. But I think one of the early benefits of the pandemic was that it really did bring organisations together, because there was all hands to the pump mentality, and there's some great learning that I think we can pull from that. But I'll hand over to Becky, who's far more cited on and I can think and address your question in a bit more detail, Paddy. Thank you. Becky, morning.
Good morning, everyone. I'm Becky Sutton, Executive Director for Community Health Services. Thanks, Paddy. Great question. So essentially, yes, it is a really exciting piece of work. I think the programme's got great ambition and great sponsorship across the system. And the vision really is to create integrated neighbourhood teams that work alongside citizens. And we really hear the voice of citizens in terms of helping us design the services for people. It's quite early days, so we do have a vision at a system level about what we think good community services looks like, and we're now at the phase where we're looking for some early adopters in some certain sort of PCN areas, so primary care networks, or neighbourhoods as we're liking to call them, to start testing out some of this methodology. It's a real bottom-up approach, so it's really around getting staff, frontline staff and citizens together to have those great conversations. If I'm honest, we are taking a leap of faith. Quite what the outcomes will be is a little bit scary at times, but I think it is that transformational piece that we can hit a target and miss the point if we're not careful. So we can deliver services we believe are what citizens and people want, yet actually they might not be the things that actually make a difference to people's lives and make them independent. Your specific question in terms of learning, so we're absolutely learning all the way along, and part of having the early adopters process is we try in 5 areas. We learn what we get wrong, we adapt our approach, but I do think if we can move closer and closer towards that vision, then actually all of that, the way we do it might be different in each neighbourhood, and we've sort of got to accept that. We will, in terms of this organisation, regularly bring reports through the strategy committee in terms of some of that learning, and I think going forward it'd be really great to invite some non-execs to come out and help be sponsors of some of those early adopters, to really help break some of the barriers around how we do this. We know it's not about organisational changes, it's not about who employs people, it's about the permission giving of how we allow people to work together. But we've got a big culture change to do as well, so I'm not naive in terms of how we go along that, and stick with it. It's not something that's going to happen overnight. In my belief, we're talking years. If you look at some of the great work in Manchester, they're 5 years, 10 years into a programme, so we've got to give it some time. Hopefully that answers your question.
Does that help, Paddy? you're on mute, but you're nodding, so I'll take that as helpful. So thanks for that, Becky. I was just also thinking back to our inputs from Neil earlier on, that actually there's an opportunity in that community context of a conversation around families and carers, both how we work with them, but also some of those pieces we talked about supporting them as well. Okay, I'm not seeing any other comments. John, thanks for that steer through so much as ever. Let's move on, if we can, to item 12, which is the digital health strategy. And Jan, it's back to you for this one, please. And I know, just to say, colleagues, we've obviously had substantial paperwork in the reading room that supported the paper that's in front of us. Jan.
Thank you very much, Paul. Jan Spencer, Executive Director of Partnerships and Strategy. So thank you. This digital strategy has also been through several committees, so hopefully members of the board will already be fairly familiar with it. So I won't spend too long going through the detail. Digital is absolutely essential, isn't it, to our work, and something that we need to continue to invest in and to improve our digital services. I think the pandemic has taught us a great deal about the importance of digital services, but we also can point to other things that that tell us that. And one of those that struck me this morning from the patient story is just that sharing of information as well, and digital is often the enabler to that. So we've set out our latest digital health strategy, and hopefully you will see throughout the strategy that we're really thinking about what does it benefit the patient throughout the way that we have set out that strategy. It has 4 key objectives. The first of those is to use technology and information to enable safer and smarter working. So that's all about the infrastructure and the actual kit, if you like, that we use and how we use it to enable us to work in a better way. The second one is that key point about digitising our healthcare records. So yesterday I was very lucky to go on a visit to John Eastwood Hospice up in Sutton in Ashfield, and speaking to the service manager there. One of the difficulties is the different in electronic patient record systems that we operate across the system and in the trust. So they're on system 1, most of us are on Rio, and they work very closely with Sherwood Forest, who are on a different system. So there's a whole load of having to do double entry. One of the things that we're really keen to do is to support the work that's going across the integrated care system, to have what they're calling a digital ecosystem, which is where we don't necessarily all have to have the same system, but that all our systems talk to each other and join up, so that when you enter it in one system, you can see it on another. So it's really, really important that we play a full role in that, and we invest in that in the trust. The third one is to provide public-facing digital services. I think, again, the pandemic taught us so much about what can be done digitally, but also we're also aware here about health inequalities. We know that there is a digital divide. We know that there are digital inequalities. We don't want to worsen those. So one of the commitments within this one is why we want to explore how we can improve our public-facing digital services. We absolutely need to be cognizant of the fact that we don't create a further divide or create further digital inequalities. I think it's also another one where we can look at work that we can do with partners. So I had a conversation with the County Council last week, and they're very, very keen to work with us on this and to see how we can join up our agendas on that. So we're going to be taking that forward. Excuse me. And the fourth one is about data, understanding our data and its context. We have an enormous amount of data that can really help us to understand population health as well as individual patient data. And we need to be thinking about how do we make the most use of that. How do we capture the data that we have? How do we analyse it? And how does it help us to deliver services that are better and also that tackle those health inequalities that we've talked about? And that this again has a system-wide application as well as a trust application. So Paul, the strategy is set out. Those are the 4 key objectives. We've kind of costed the strategy at a very high level, and folk will see that is around 59 million. That's spread across the 4 years, so it's roughly 15 million pounds a year. We don't have a pot of money that has been given to us for this, so we will have to go and seek budget and grant from various pots. We have earmarked within the trust around £2.5 million a year within our capital programme to ensure that we keep up and that we keep our kit up to date, that we have the infrastructure that we need, and so we can maintain with that. But in order to do the investment, we would have to seek out money from various national and regional pots, particularly the Unified Tech Fund, which is the NHS fund. At this stage, it is not yet been nailed down what we can get for this year. So kind of a bit of a word of warning. This is our ambition. It's right for us, I think, in the strategy to set out our ambition. We do still need to make sure that we can nail this year's objectives in terms of the money and taking that forward. But we remain very, very committed to that, and we do remain committed to ensuring that, you know, the digital work that we do supports the work of patients and our staff, and the strategy, I just wanted to assure the board, has been developed with a lot of engagement with staff in order to ensure that it is reflecting what their needs are. So great. Hopefully the board can approve the digital health strategy. Thank you, Paul.
Thanks, Jan. And there is a chunky document there, and it is also, it really does show through the ambition and the support and work that you've described there, Jan. Stephen, please.
Thank you, Chair. Stephen Jackson, Non-Executive Director. I just want to welcome the strategy document, and in particular the way that the strategy has been put together across the system. You know, we're clearly advantages are there, and personally, I also welcome the fact that we'll be able to get access to the data, particularly as we start to attack one of the key priorities of identifying and tackling areas of health inequality. So excellent report, which I recommend and commend.
Thanks, Stephen. Carolyn, please.
Thank you, Carolyn White, Non-Exec Director. Jan, thank you for this, and congratulations. The strategy document in the reading room is a really good read, I think. It's very clear, very straightforward in terms of what we are trying to do. It also feels quite ambitious, which is great. So my question is, do we have sufficient resources for clinical staff to work within or alongside the IT team to help the transformation that we need to really get the benefits from the proposals within the strategy?
Yeah, thank you very much, Carolyn. So first of all, I should acknowledge this strategy was developed before I took up post. I take no credit for it, but I would like to credit Cathy Footaway, our Chief Digital Officer, who's put this together and really deserves the plaudits. Secondly, Cathy has worked really, really closely with Chris Packham, our Deputy Medical Director, and Chris is absolutely passionate about data, how we use data, and he has worked really hand in glove to ensure there's a very strong clinical voice in how this is put together. Chris is also, I don't know if Sue would like to comment a bit further, but Chris has also acquired some data scientists to work with him so that we can have that investment and that input, if you like, from the clinical side, Carolyn, to really ensure that we can drive this forward. So I think the Trust has supported that input that you've just talked about. Clearly, we've got more to do to find the capital to be able to take the strategy forward. But I think in terms of the resource within the Trust to support this work, I feel very confident, and Chris is, and I should also mention that Anne-Maria is in the middle of recruiting a Chief Nursing Information Officer as well. So we have invested in some posts that really help support the clinical input.
Can I just clarify that a little bit further, Jan? Sorry, my question really is around people working alongside clinicians, because my experience of this in the past is if we don't help clinicians transform the way in which we work, and we just try and do what we do now in a digital form, and it doesn't work. So it's great to hear about the lead nurse, Chris's involvement, but it's really about
sorry,
my phone's ringing in the background. Some foot soldiers who will be in amongst our clinical staff, helping them to re-engineer the way in which they work.
So thank you. I'm sorry, Carolyn. Yes, I completely understand what you're saying. If you think back to last month's board when we had the presentation from colleagues from Lings Bar, and one of the things that they'd made the point was we needed more investment in training to help us develop. They'd got a new system that had been put in place, and they thought the system worked well, but they did make the point that we needed to have invested more in that training, in that working alongside at the beginning. So that's a lesson that we've learned, and that's what we're taking forward now. As we take forward new initiatives, we really need to make sure that we have that working alongside, and that's something that Kathy has absolutely taken on board. So yes, your point is really well made, and a good reminder to us, but it is something that we've picked up from that experience and that we will ensure with future rollouts. Thank you.
Thank you. Thank you.
Great. Nigel, and then I'll try and wrap up. Nigel.
Thanks, Paul, and thanks, Jan. I agree with colleagues' comments. It's not a question, it's a comment, and it might sound like the dead hand of finance, I'm afraid, but I think it needs to be said. The 59 million is not the end of it, is it really? Because even if we were given access to the capital, there's the question of depreciation, which on technology tends to be a fairly short life. So we might, we might end up, even if we got access to this money in a capital sense, facing a fairly hefty additional depreciation charge that will hit the profit and loss account. So we need to be mindful of that. So whilst I support the strategy and agree with what colleagues have said, there is a question in my mind about affordability of this against all the other competing priorities.
Great, thanks, Nigel. And I think it's a really important one, and it's where some of your focus and committee focus will go. Alison, I didn't know if you wanted to come in on that specific point before I wrap up. Alison.
Yes, thank you, Paul. Alison Wild, Exec Director of Finance and Estates. So yes, Nigel, you make a very good point. And I think that's where the further work is needed in terms of our financial strategy over the next 5 years. There are some real big ambitious projects in terms of the digital strategy, our trust strategy and our estate strategy. And we need to plan ahead for these as much as we possibly can once we make those resources, if the resources are available from external funding sources. But it is something we're totally aware of, and we'll be planning into our medium and long term plans to ensure they are affordable before we embark on them. So thank you.
Great. Thanks very much, Alison. So Jan, lots of support from around the board table, including an endorsement of your thanks to Kathy for her work on leading this. So we're asked to support and approve the strategy. Could colleagues give me an indication, please? Take a couple more. That's great. Thank you very much. Let's move on. If we take the next item, the estate strategy, and then we'll take a short break before we continue on after that. So if we could, Alison, stick with you for the estates strategy, please. And again, another piece of chunky reading for us behind this paper.
Thank you, Chair. Alison Wild, Executive Director of Finance and Estates. So the estate strategy here is at the board for approval, and it is about our strategic intent with principles and an aspirational approach to the strategy. There are two recommendations. One is to approve the strategy and the second is to support the approach of a 12-page briefing for onward publication and circulation more widely across the trust and our external environment. So in terms of the aims of the strategy, it's about the outcomes about ensuring high quality and working environments that are accessible and digitally enabled, linking with Jan's digital strategy that she's just been through, and to ensure that they're fit for purpose in terms of supporting agile and remote working going forward, and that all our properties meet our quality standards. The other part of that is that the care environment support therapeutic interventions and recover better patient outcomes. We need to ensure the best use of our estates, rationalising where possible and reducing backlog maintenance, which has been an issue for us as a trust, as a system over the past few years. And we need to support the wider financial improvement programme in terms of productivity in clinical and corporate services. So I think overall this is an internal strategy that is aspirational. We've, like the digital strategy, we've not necessarily got the answers in terms of the whole funding of this, but we feel we need to aspire to this because this is another one of those that we need to probably invest to save. I think as a trust, we also need to recognise that the wider picture in terms of the integrated care system and the potential future needs of properties in terms of our public estate. And we're in a really strong position in terms of our community assets and buildings. I think we are looking at a strategy for disposal of properties. However, we want to ensure we aren't disposing of properties that could be for the wider benefit of our patients and population across Nottinghamshire that we could share with our partners. So I think we need to maximise the use of our estate while modernising and ensure that it supports place in our system. So I wasn't intending to go over that in much more detail. We've been through this at Strategy Committee. It's been under quite a lot of scrutiny. It's been out to engagement with our clinical services. And there's been quite a lot of updates that have been taken forward by our estates team. So I'll pause there and just remind everybody it's for approval and for onward for the approach of the 12-page briefing in terms of external circulation. Thank you.
Great, thanks Alison. And Trevor, I don't know if you just wanted to give a comment just to give us the assurance about the conversations and discussion and scrutiny that's happened at the Strategy Committee. It may be helpful just getting that on our record.
By all means, Chair. Trevor Orman, Chair of Strategy Committee and Non-Exec Director. Yeah, the review both for the estates and the digital strategy have been comprehensively reviewed at the Strategy Committee, and I'd have to say both pieces of work are of really high standard. Just focusing quickly on the estates, I think the fact that we've got the depth of report that we can backtrack to and make sure that we're delivering on that strategy. And the challenge is going to be, as Alison has said, making sure that we integrate with the wider community within the wider trusts in our area. So that's going to be one of our challenges. But the other challenge is for our continued maintenance that we've got to make at the forefront. But the overriding strategy, I think, is excellent. And the 12-page summary and the 2-page report that will go with that gives everyone the ability to understand the direction of travel and if we need to course correct. So it's certainly got a solid approval at the Strategy Committee, Chair. Thanks
very much, Trevor. So I'm not seeing any other hands going up. So Alison, you've asked for those two pieces for us to approve the strategy and then to support the 12-page briefing. I'm sure there are many of us who would absolutely advocate for a 12-page briefing versus 100 pages of documents. So very supportive of that as part of that engagement. Formally, colleagues, can I just ask you to give me an indication of if you support both of those, please? That's great. Thank you very much. So let's take 10 minutes for a comfort break and then we'll resume at 5 to with our next item. Thank you very much. Okay, if we could restart, please. And we're going to move to item 14, the integrated performance report. Just before I go to Alison to introduce this, John, do you just want to give a couple of reflections before we move into this item?
Yeah, thanks. So just to refresh people's memories, we had a conversation previously about realigning some of the board subcommittee work more closely to exec portfolios, and there was a particular conversation around where performance overall sits. And at the moment we have, by the dint of the way that things are organised, sometimes some performance data comes direct to board, which is a relatively unusual position. So we're looking in the executive how we can bring a couple of options perhaps to discuss how we can change the constitution of a couple of the subcommittees of the board. So for finance and planning, and possibly to become finance and performance. So there's there's greater opportunity to give some real deep dive oversight and scrutiny of some of the performance data before it comes to board, so that the board becomes much more to do with escalation and particular focused pieces, and that the planning moves to be much more closely aligned with the strategy committee, as the work is often related anyway. So, and that isn't the case today, but just to say, hopefully that we can get something described that meets the needs to make us a bit more streamlined at board and a bit more focused on the critical pieces in the board committees. And that's what I just wanted to say by way of introduction, Paul, before handing over to Alison. Thank you.
Great, thanks. And I think if we can just sort of hold that in mind, because I think I was reflecting that there's sometimes a lot of detail in the integrated performance report, and actually we just need to hold on to our oversight and to use the jargon, that helicopter view stuff. So with that intro, Alison, over to you to give us the usual steer through, please.
Thank you, Paul. Alison Wild, Executive Director of Finance and Estates. So I'm here to present the Integrated Performance Report for month 1 of the financial year 22-23. It's here for assurance, and it's about our performance against regulatory standards and internal targets. Just to highlight that reports here for reports by exception, about failed targets and about any significant variation against those targets. I'm going to hand over to my exec colleagues in the order of the integrated performance report. So we'll start with quality, and Anne-Maria. Thank you.
Thank you, Alison. My name's Anne-Maria Newham. I'm the Executive Director of Nursing AHPs and Quality. And I'm going to take you to page 2 of the IPR, which is page 38 of your board report papers. So the first section is around wards with safer staffing levels that are lower than 85%. The reason that they're often below 85% is because of sickness, absence, and vacancy. So that's when they've not been able to fill all of the shifts. Now, we have seen for the month of April a slightly improved picture in some areas. So we still have 14 wards that are showing low staffing levels, but these are in a kind of the same areas we've had before with forensics. However, we have some good news that no community health wards have been reported below 85% for April, which is the first time in 10 months. And we actually, based on the overall figures, the safer staffing is now within control limits as well. We do still continue to see some pressures concentrated within Rampton High Secure Hospital. So that is the summary. I do want to just also bring people's attention to page 42 of your papers or page 6, where it says COVID patient outbreaks. On that, as you can see on the right hand side, the third one down, that's not the amount of outbreaks, but that's the amount of patients that have had COVID. So I just wanted to reiterate that number 42 for April is 42 patients, not 42 outbreaks. And I'm happy to take any questions.
Thanks, Anne-Maria, and that's a really helpful clarification, I think, for us on that number. So I'll just pause to see if anybody's got any comments or questions they want to pick up with you on those highlights. Not seeing any. Alison, do you want to steer us on, please?
Thank you. I'll move on to the largest part of the report now, which is our people and culture overview. So I'll hand over to Jen Guyver. Thank you.
Good morning, I'm Jen Guyver, Executive Director of People and Culture. So just taking you through some of the key issues around our people stats. As you can see from the summary on page 9, not page 9, page 8, many of our people stats are flagging as red. So just to pull out particular areas of concern, our absence rate for April continued to be high at 7.5% and remains just touching the upper control limit of the SPC chart. Appraisal uptake is 78%, which has seen a small dip, as has mandatory training at 84%. What the board will see from the rest of the papers is that obviously that's not where we want to be with our people stats at all, and what we've offered is some assurance around the programmes of work that are in place and progressing around that. So just to pull out a few things, recruitment, it's all about recruitment at the moment, and hopefully people will have seen the variety of campaigns that we've had going on in a multitude of medias. So that goes from face-to-face recruitment roadshows, where we're actually offering posts and interviewing in situ, through to digital billboards, social media, and then also some of the more traditional press, such as the Health Service Journal. Secondly, our international recruitment work stream is now underway, and Terry Mahaki joined us a couple of weeks ago, so that's really great progress. And then from a COVID perspective, some of the measures that we've had in place, we've been able to relax, which should help us from a mandatory training point of view. We've increased our room capacity for face-to-face training, which obviously will help. And we're soon going to be moving back to a face-to-face induction programme, which, as well as being really important, I think, from a staff engagement and a organisational entry point of view, those new members of staff will be able to do the mandatory training that they require straight away, rather than relying on their own motivation to get it done through e-learning. So hopefully we will see improvements over the coming months, but as we stand, we're not where we need or want to be.
Great, thanks for that, Jen. And I realised very belatedly I should have welcomed you to your first board meeting in your substantive role as the Executive Director of People. And I think we're familiar to seeing you the last couple of board meetings, so apologies for that. You are very welcome, and I know that this is a key part of what you're getting to grips with. So I'll take Sue, and then Nigel, and then Carolyn, please. Sue, please.
Yes, thank you, Paul, and thank you, Jen. My name's Sue Nixon, one of the non-exec directors and also chair of the People and Culture Committee. Jen, I offer my congratulations too, alongside Paul, and I acknowledge we've had quite a lengthy debates, haven't we, and open and frank discussions at the recent People Committee. So a couple of questions that perhaps maybe I could just ask you to expand on, please, if you wouldn't mind. You've talked, one's about recruitment, and you've talked about the push on recruitment fairs. Could you just help us out, please, with what sort of responses have you had at those attendances, and have any of those converted into expressions of interest or applications for jobs, and, you know, the conversion rate, if you like? I know it's a bit early, but how's that gone?
So it is probably a bit early to give you an exact conversion rate, but we're increasing the number of fairs. So during fairs, roadshows is probably a better word. During May, we were out on the road quite a few times. So there was the team were at Arnold Lodge at the Notts County Fair, also up in Mansfield for the Sherwood Oaks campaign. And we were attracting sort of 40-50 people to each on average to those events. For some being able to, as I say, interview on the day. I think one of the stats was we offered 10 HCA jobs at one of the events on the day. So I think that's probably something I'll take in action for the people committee, so to do some statistical overview, but we need a bit of time for conversion because obviously employment checks, etc., takes some time.
Yes, thank you. Paul, may I just do my other question as well, if I may? I've got a load, but I'll limit myself to two because I know other colleagues are keen to explore things with Jen. The organisational development issue, you've put that down as a positive. We've been talking about this and we know that we haven't been able to progress this as far as we wanted to because of COVID. But what are you hoping to get out of that? What are we going to be seeing as a mark of success from these programmes? How is that going to help change the statistics that you've been saying aren't quite in the right place at the moment?
So I think if we just rehearse the history very briefly, the organisation did a huge engagement activity with our staff, our colleagues, around defining what the values should be for our organisation, which you've all got on your backgrounds: trust, honesty, respect, compassion and teamwork. They were launched at the board in February 2020, and then what would have happened if what we know then happened in March 2020 hadn't happened was a further engagement around values into practice. So what do these values mean to a healthcare assistant on the ward, to a district nurse out in community, except to an admin member of staff, and that hasn't happened. Essentially what we're doing at the moment is picking up that momentum through the OD programme, but it has to have a slightly different slant given that time gap. So Alex Lyon and the organisational development team are now back from COVID redeployment. They're working with our leaders around the Creating Capability Changing Culture programme, which essentially aims to embed those values at a team level. So what does that mean for our team? And that's different for every team, isn't it? As part of that programme, we do a training needs analysis with the leader and the team in terms of what they need, so then we can offer that. Linked to that, we've just approved at the exec team meeting a new ward manager development programme, so that all of our 66 ward managers will go through that same programme. But that will amount, I think the impact on numbers of staff then will start to be felt once we get momentum on that programme.
Okay.
And in terms of outcome, sorry, I didn't answer the end of the question. The outcome, I've said this a few times, is when we get our staff survey results next February, we all want those two key indicators to improve, don't we? Would our staff recommend Nottinghamshire Healthcare for a place for their family and friends to receive care? And would our colleagues recommend us a place to work? And I think that's the ultimate test of the work we do over the next, well, 6 months, not even 6 months till the survey goes out again.
Great.
Okay. Thank you.
Thanks, Jen. Nigel, please.
Thanks, Paul. Hi, Jen. Easy question from me. I think it's the sickness absence really is a cause for concern, isn't it? It would be odd if we went through the board meeting and didn't bring it up when it's 7.5%. There's a very helpful chart on page 13 the bar chart that shows that if you exclude coronavirus absences, infection prevention and control, sickness absences 5.4% April 22 compared to 4% in April 20. So it's the same month, time of the year, but it's gone up by a third, and it's not coronavirus. So the question I've got really, if it's not coronavirus, what is it that's causing our sickness absence to go up by a third? And is it, broadly speaking, the same people taking a third more absence, or is it a third more people taking absence?
So the People Committee received a deep dive on absence at our last meeting, which was the May meeting, which split a lot of the data by absence types, reasons, highlighted the areas of highest absence, and then described some of the actions that we're going to take around that. Putting it broadly at a board level, I think we need to get back to good attendance management. I don't mean that in a punitive way, in terms of making sure people have returned to work, so when they get back to work that we are meeting with people regularly if they're off long-term sick to bring them back if they can. People generally, we are better in health if we're at work. But secondly, combine that with our wellbeing offer, which is just gaining momentum, because we've got Jonathan Wright, who's commenced in the last few months. So it's in the board report, but I think it's a two-pronged work plan really going forwards, because you're right, increasingly, all things being equal, the COVID absence should start to decrease, shouldn't we? And we need to ensure that that absence level doesn't stay the same. But I'm sure we can share the People Committee paper if you want some of the details around the stats.
Does that help, Nigel?
Yes, thanks, Paul. Thanks, Jen. I wonder if you haven't already looked at it, Jen, I wonder if you could just look at whether it is the same group of people who are taking absence more frequently, or whether it is a wider cohort of people. That
that's a good idea.
Just there are many people in the workforce who don't take any absence at all, and you know, is that number shrinking? It might suggest different causative factors.
Great, thanks, Nigel. Carolyn, please.
Thanks, Paul. Carolyn White, Non-Exec Director. Jen, in the areas that we need improvement, so I'm looking particularly around training and supervision, kind of understand why those targets may have slipped due to COVID and sickness absence and things. However, those statistics will hide a multitude of sins, won't they? So there will be some areas that are performing much better than we're reporting, and there'll be some areas that are performing worse than that. So my question is, are we clear about the areas that are performing worse than our overall trust statistics, and are we focusing our efforts on improving those areas first?
So essentially, yes, that's work in progress around each of the statistics. That's essentially what the deep dive for the People Committee prompted for attendance. So in pulling all those stats, understanding the data, and we have heads of workforce who are HR business partners linked to each of the divisions. They know which are the areas of highest absence, and should then be working with the divisions around that. It won't be a surprise, because we know what the areas are from a variety of other data, don't we? But we need to take that forward in terms of getting into the detail of each of the our data sets. Going back to the OD programme, we are very much we changed our OD approach from the more traditional, whoever puts their hand up and asks for a team timeout day, get to the OD team's time, towards looking at the data and deciding where the teams in most need are. And it's not who shouts loudest, it's in a programme of activity agreed with the divisions, agreed with the business partners. So yeah, I think we're at the start of that journey of being more intelligent around our efforts and our input from a people perspective.
Okay, thank you.
Thanks very much. So Thanks, Jen, and let's move back to Alison. And Alison, also apologies to you. I should have welcomed you in your substantive role as well. Well, I think, again, I got used to you being around the table, having previously held the interim role, but congratulations and welcome to your first board in substantive role. But steer us on, please, Alison.
Thank you, Paul, and appreciate that support. Thank you. So we're moving on in the integrated performance report to our operational divisions, and I'd like to start with mental health services. I'll hand over to Julie. Thank you.
Morning, I'm Julie Atfield. I'm the Exec Director for the Mental Health Division. I'll just start off by a couple of positives, flagging the improvement around the 72-hour follow-up performance and rectifying the data issue that we had around that performance, and also just to refer board colleagues back to the Chief Executive's report, where it highlights the improvement in psychological therapy waiting times, where the number of people waiting is now reduced by 2/3. So I just wanted to flag those up from previous discussions with the board. The main aspect that I want to highlight to the board should not be a complete surprise to the board. It is about out of area placements. The board have been aware of the pressures in terms of access to services, particularly over the last quarter, which have driven up demand in terms of access to beds. So that's an area of focus, obviously, for us, and just to be aware of some of the underlying drivers for that. So we did have that peak in admissions at the end of April. Particularly, we had a very difficult period where the admissions would double the previous periods before and after. So hopefully that peak has gone and passed. But the other underlying issue is about the length of stay, which for our acute wards is now 5 days longer than it was in October last year. So the board's familiar with the work around delayed discharges and the multi-agency discharge events. They've been continuing to run, and the service has got its quite sturdy action plan about reducing length of stay. So that leaves us with the current position of the use of probably 10 beds in excess to what was our previous plan. And those have been on a sort of what we call a spot purchase arrangement to help manage the clinical pressures in the front door. So it was, and the board were aware that actually the demand for beds was exceeding the supply that was available, both in our own beds and in the subcontracts. So the avenue taken was for obviously safe admission to those patients of actually local spot purchase beds. So we have diversified in terms of the providers that we're using, and we have some technical changes to make with a new provider to hopefully allow some of those beds to be categorised as in area, because they are actually very local to us. So that technical adjustment might benefit us. However, we still need to improve our run rate probably and reduce the number of beds. So we have got a recovery plan, which we will be going to the executive team and to Finance and Performance Committee. Now, what that is based on is an early improvement actually around the use of our own beds. So that's continued work on length of stay, but also to step up the use of our dormitory beds. So our COVID restrictions around infection prevention and control have limited the use of quite a few of our dormitory beds. So we will be able to, and we have agreed the protocols for how we might increase that use. So we do plan to reduce those spot purchase beds by the end of July. So we've got a proactive plan to reduce that. And I'll end on a positive note to say that actually the mental health services are at Opal 2 today, which is its lowest operating escalation level since 2021. So whilst it's been difficult and this is an accumulation of pressure, I'd like to be optimistic and say that there will be some improvement. Thank you.
Thanks, Julie, and that's a good point to sort of pause on, just to recognise incredibly hard work that's been around for so many since 2021. Nigel, let's bring you in.
Carolyn, were you before me? Or you happy for me to go?
I think that was the previous. That was the previous one, right. Nigel. Don't worry.
All right. Thanks, Paul. Thanks, Julie. Just a few comments and a question about the out of area bed placements. I think you can see from the graph that the demand for beds is fluctuating and very difficult to predict. So I think it's not a failure to have a spike on this where demand is variable and supply is fixed. This zero out of area bed days ambition goes back a few years. It probably wasn't credible when it was first announced and doesn't seem to be credible now, does it really, to be aiming for a target of zero, and probably never will be. What I'm interested in though, probably not here and now, but some future point, is not so much the number of out of area bed days, but have we got any outliers in terms of patients who have been out of area a long way away for a very long time? Because that really would be a patient experience issue, but someone being out of area, we haven't got the beds for a week or two and they're just across the border, is not anything like a serious issue. So I'm just trying to probe really that, are there any patients who are having a particularly bad experience here, or is it temporary and nearby?
Okay, so I'll just respond to those comments. Firstly, I think, you know, the target around out of area, I think is laudable. You know, it has all the benefits for families, carers and patients. It's difficult for some organisations to fully achieve that because of things like structural issues around their own estate. So I think it's difficult. For us, in terms of your particular question about people sort of stranded out of area, I can assure you that there aren't numbers of people stranded out of area, and there aren't even really individuals stranded for a long time. What we do have though is, and we have had particularly over the last 2 months, is particularly female patients waiting to come out of a psychiatric intensive care unit to step down, and there's been nowhere to step them down to. So we have had that blockage. That has only started to ease actually this week. So there will have been patients waiting to step down out of psychiatric intensive care for about 8 weeks when they didn't really need to be there. So that is very closely managed and monitored, and we do try to obviously move people and get the flow moving, but the last 2 months has been very, very difficult. So
I think it's perhaps also worth to say, Julie, that and this doesn't detract from the challenges we've got. This is something that's happening all over the country as well in terms of demand. I don't think we're outliers in this. Okay, I'm not seeing any other questions or comments coming up. So Alison, steer us on, please.
Thank you, Chair. I'll hand us over to, just a minute. I think we're on forensic services next, please.
I think have we got Becky first? We got community. Okay. Is community before?
Oh right, apologies, Becky. So over to community, thank you.
Thanks, Alison, not a problem. So Becky Sutton, Executive Director for Community Services. So I'll take the report as read. Just a couple of things to highlight today. We continue to perform very well in the new measure that we've got in community services around 2-hour urgent care response. 94% of patients against a standard of 70%. But I'm going to leave that one there because you will hear a little bit more about that service in a video later on in the board. There's also in the paper a continued report around our waits around 13 weeks, so at the point somebody's referred to being seen. And you will see, whilst that is still worrying and we still have a number of patients, you remember last month I brought quite a detailed deep dive around community waits, and whilst we do have them, they're reasonably low numbers, and you will see that starting to recover. What you will see is another jump at Lingsbar Hospital around their average length of stay. So again, you'll remember that Lingsbar is our rehabilitation hospital for patients that come out of acute. And there's a number of reasons for that. This is compounded by some of the issues that we have in the home care market in social care. And whilst there's lots of plans as a system to improve those, we haven't seen that availability increase particularly. And particularly in April, we had a number of wards closed with COVID, which does mean we can't necessarily move people out of hospital in a timely manner or admit in. We do have a robust improvement plan around this, and there's an awful lot of work going on in the system around creating integrated hubs for discharge, and there's £8 million in the system to try and increase our intermediate care capacity. So again, services that re-able, recover and rehabilitate patients coming out of hospital before they need ongoing care. So I do expect that length of stay to come down, but I think it will take some time with the few issues that we currently have around moving people out of that facility. Paul, that's probably all, Chair, I wanted to say, but really happy to take questions if there are any.
Right. Thanks, Becky. And I think just giving us that context of the challenges of other parts of our health and care system and how they impact on people in our care is really helpful. So I'm not seeing any hands going up. So Alison, steer us on, please.
Thank you. I'll go on to the right ones this time. So this time I'll hand over to our Forensic Services and Sue Elcock.
Hi, Sue Elcock, Exec Director of Forensic Services. So in terms of what's in the performance report this month for us, it's actually pretty stable in terms of previous months as well. There's not a huge amount to share. I did want to particularly pick out about the fact that we've had 0 lone working shifts, because obviously we've been reporting to board that's been an area of concern, and that I think mirrors what other clinical divisions are feeling in terms of, whilst it is difficult in terms of our staffing requirements, our absence, our sickness rates and availability, things are, I hate to say this, you know, somewhat settling a little at the moment. So I'll say that with bated breath. The occupancy figures are in there, and I've talked about before about the fact that we're looking at how that is sort of made meaningful to the board, because occupancy on one hand at the end of the day means people aren't needing our beds, which could be a good thing rather than it just being a target driven sort of basis. So we're working on that. I think the important thing is that we don't have huge waiting lists. So I've reported to board previously, particularly in iSecure, about waiting lists for the Learning Disability National Service, which have been really well managed. So in that sense, I'm going to stop because those are the highlights really.
Great, thanks, Sue. Again, I'll just pause to see. Again, I'm not seeing hands. I think you've described, you've given us a really clear picture of where we're at with the forensic elements here. So Alison, back to you.
Thank you. Alison Wild, Executive Director of Finance, and I'm here to cover the finance section of the Integrated Performance Report. So in terms of our revenue position, as at month 1, the end of April, we are actually on target in terms of our plan. However, within that, there is some significant variances. Our pay is over 800,000 under plan, and that's due to leavers and also about us being a bit unable to recruit to our assumptions in our plan. To offset that, Julie has covered in terms of her mental health overview, is that we're over plan by just over 900,000 as a result of additional spend on out of area beds. I won't go into that in any more detail because I think Julie's covered that in the last section. In terms of our financial improvement targets, I think it's safe to say that we are back to business as usual as an NHS, and there is now an expectation of financial improvements, the targets and delivery of those targets. In terms of our trust target, it's currently sat at 20.3 million, which is a challenge going back to the regime of the finances in the NHS. So we are prioritising the work to actually take that forward, and we'll be feeding that through Finance and Planning Committee, which will be hopefully Finance and Performance Committee going forward. Capital spend, there's nothing major to highlight. We're just under plan, but I'm not concerned at this point in the year. Most of that is about delays in supplies that are changing daily, but our overall plan, which is in has been reported to Finance Committee, is achievable, and I'm assured in terms of spend and our ability to spend against that capital. So nothing else to cover really, other than to say that obviously the whole of the integrated performance report is here for assurance to the board. Thank you.
Thanks, Alison. Stephen, let's bring you in.
Thank you, Chair. Stephen Jackson, Non-Executive Director. Two questions, if I may, Alison. The first one is it's good to see that you've come out at the bottom line with a positive variance against budget for the first month, and it's always good to get off to a good start. But in some ways, the way that variance is made up is not as you would have wanted it. I suspect. We've got savings in staff areas, but really we'd like to recruit people. We're making up for that with expenditure on temporary and bank staff, which is not really what we want to do, and we're also behind on the financial improvement. So some of those variances look actually quite worrying if we project them into the future. I wondered if you could tell us your own view on that, and how we're going to try and address some of those issues.
Thank you, Stephen. Yes, I'm happy to take those questions. So if we take the out of area beds first, I think Julie's described her plan to actually reduce those out of area beds by July, and we'll be monitoring that alongside Julie in the clinical division to ensure to see where we are against that. In terms of the recruitment, yeah, it is worrying. There is a challenge for us to provide safe and quality services to our patients whilst being unable to recruit and having people leave, and particularly in the forensic division. So I think a lot of the things that Jen has described in her people strategy and how we need to move forward on that will address that. However, at this point, I am not assured in terms of the delivery of the recruitment against that plan. I don't think we're unusual as a trust in terms of that recruitment challenge, and I think that's going to be a wider challenge, and probably one of the things that Jan Sensia described earlier about how we tackle that as a system within the ICS to try and deliver that recruitment. So there's a lot of work happening, and will be fed through the committees feeding the board. In terms of our financial improvement plan, it's one of my #1 priorities at the moment, that we are leading through identification of financial improvements, and Finance and Planning Committee have seen an early draft of that, where we have got some schemes that could add up to the region of 20 million. However, there's a lot of high risks in there, and there are a lot of things that are still not been drawn up and are still in the pipeline. So we've still got a lot of work to do. I don't think we're unusual in the system and in the NHS. However, that doesn't help us in terms of the financial position. Our aim is to make us financially sustainable, so we are looking for recurrent FIPs. However, it's inevitable this year that there will be a large non-recurrent element of that due to the non-recruitment of the staffing resources. So I think it's something that as we go through the year will be featured more prominently in our IPR report in terms of financial improvement targets. Does that answer everything?
It does. I mean, clearly you've got a lot of challenges there, Alison, and you know, that'll need a lot of effort from a lot of people to pull it round. But you know, I hope you can get on top of it. My other question is concerning COVID, and if I understand things right, we've essentially taken out any additional COVID costs out of the budget, at least for the whole year. I can't remember exactly when they were taken out, but they are taken out. Given that as we've heard, you know, that COVID is still impacting us to some extent, is COVID and COVID costs, is that a risk, do you think, going forward?
Thank you, Stephen. And yes, good question. COVID costs are a risk to us, to the system and to the national NHS. The national guidance, I'm not even sure it's guidance, the national direction we were told to do to take out those COVID costs, and that we would continue monitor them as a separate item, and then potentially use that information to go back to the national teams about resourcing that. I think there is still a national expectation, though, that COVID costs should go, and that we are now in business as usual, and that we should be building in COVID costs into our normal planning process, and not with no expectation of additional funding for that. The only exception to that this year will be the vaccination programme. Everything else, there is a view that it should be contained. However, we will continue monitoring that as a trust and as a system, and be talking to our regulators on a regular basis to make representations should they become unmanageable. But you're right, it is a risk to us.
Okay, thanks, Alison. Thank you, Chair.
Great, thanks. And Alison, I think I'm getting a real sense that obviously the financial improvement plans will be a part of what we continue to get scrutiny of, both through committees and, if necessary, at board level. Carolyn, you wanted to come in. Carolyn.
Yeah, thank you. Alison, I think you've partly answered this question through your response to Stephen, but it is around the financial improvement plan. I think this is a real concern for us, and I hear what you're saying about you and the teams working really hard. I just wonder if you can give us more clarity on timescales, because we're approaching now the end of Q1. We still don't have a plan, and therefore we're just pushing everything into the end of the year, and inevitably the winter period is much more difficult for organisations because of pressures on operational services. So I'm seeking assurance really in terms of how quickly we might see this financial improvement plan, and so that we can then be assured that, you know, we've got something to work out.
Thank you, Carolyn. Yes, and in terms of timescales, there is a plan to take another paper back to Finance and Planning Committee in July, which should give more clarity on that. We have done the initial one in our May meeting, and in terms of assurance at this point at board, of that 20 million, 6 million of that is already identified and is being delivered. So that's the full year effect of previous years, which is leaving a gap of just over 14 million. We have schemes that have drawn up, well, ideas that are drawn up to meet that target. We just need to do that further work in terms of phasing and risk of delivery, which we are expecting to go to Finance and Planning Committee in July with.
And can I just follow that up as well, around quality impact assessments, Alison, and when we might expect those to come through Quality Committee?
So that will be different timescales depending on the individual business cases, but that all business cases that have an impact on clinical services will need to go through the quality impact assessment. So a lot of that is dependent on how quickly the schemes move forward within the divisions and with the exec leads, but certainly in terms of assurance to next Finance and Planning Committee, there will be some timescales and milestones with an expectation against all the large schemes, so that we can see, we can at least plan ahead about when the QIAs will need to be done.
Okay, thank you.
I think Alison, you're getting a strong sense of concerns that I think you share as well, about us being able to get these financial improvements bottomed out as fast as we can, and we all know the impact of further delays on that, but also being mindful that in terms of going through those proper processes of using the committees, it may be that when we get to our next board meeting, actually we've not had those bites at those committees. So we just need to be mindful of that as a board. But I think there's a strong sense of support for you in really keeping the focus on this as you described. So, okay, thank you very much. And just that reminder about John's introduction to the Integrated Performance Report, and that we'd welcome the execs doing a bit more thinking about how that gets brought through, and those pieces about how performance fits with our committee structure, so that we're able to give the right kind of scrutiny prior to board across all of that work. So let's move on to item 15. John, freedom to speak up, Guardian's annual report, please.
Yeah, thanks, Paul. I'll take the report as read, and also reference that there are 3 documents in the reading room, learning lessons, the Ockenden report on maternity services, which we discussed briefly at the board either last month or the month before, and also a really interesting report from some issues in West Suffolk, which I'd referenced you to. I'm not going to go through this in any detail, just a couple of things to pull out. It's already been to People and Culture Committee. It's coming today for assurance. I'm just introducing it on behalf of Shirley Higginbotham, who's moved back to Sherwood Forest now. So we currently have a vacancy in the corporate director role. Just a couple of things to say. The first one is that you'll be aware that on an annual basis there's something called the Freedom to Speak Up Index, which ranks organisations in a league as to their culture and performance around all things FTSE. And in previous years, or most recently, we were one of the most improved organisations in the country, and that process has been suspended for this year whilst they look at some of the components that make up that index. And so if you're looking for how we maintain that momentum, we'll have to wait a bit longer. Also like to highlight, we have a new deputy started in post in May, Natasha Bowen, which increases the complement of Guardian, both capacity but also experience and skill set, and just to formally welcome Natasha to her role on behalf of the board. It's such an important function overall. A bit of content in terms of the figures. So 144 issues raised in that year, which is an increase in 60%. We always have a conversation about whether that's a good or bad thing. My view is that it's a good thing, because it fits with our values. It's important that we know that they are where the issues are and what they are, so we can respond and tackle them. It's also important that all our colleagues across the organisation feel confident that they can raise speaking up concerns. The 2 biggest categories are attitude, behaviour, but more recently quality and safety too. And then just to finish, both the chair and myself meet with Simbi, who's the lead for this, on a quarterly basis to review themes and feedback. And we had a good session a couple of weeks ago. And that's as much as I want to say. Paul, happy to take questions. Thank you.
Thanks, John. Nigel, please.
Thanks, Paul. Thanks, John. First, an observation, really. It's interesting looking at the 2 graphs on page 4 of the report, that's showing a kind of switch in the the types of concerns being raised historically. I think, like a lot of trusts, it's in the attitudes and behaviours column, but in Q4, the report helpfully points out that actually it's more about quality and safety. That kind of fits really with the pressures that we know are in the organisation and what the staff survey told us. So it's nice, well, it's not nice. It's not nice to see it, but it's nice to see it fitting together. And I think that's giving us a strong indication of where pressure points are being felt. My question, John, is there's a comment made in the report about a possibility or a suggestion that the number of concerns raised in Q4 is lower. I'm not sure it is materially lower in the way these things work, but that it might be due to periods of absence of the guardian. Do you think that in the absence of a guardian would actually reduce the number of concerns being raised?
Hi Nigel, yeah, good question. I think that's probably Simbi, the lead, being sensitive to her own personal circumstances. She had a quite protracted amount of compassionate leave due to a family bereavement, and put that in the report. So I think it goes to her sort of commitment to doing the role 100% as well as she can, and there may well have been, she felt, because she wasn't there picking up some commentaries and emails, that there were less. But I think you make a good point. I think there's probably other factors too. Okay. It's not just the absence.
Okay, thank you.
And if that was a factor, having the deputy in post now helps us make sure that there's some better spread across and being able to pick up if there was any impact there. So thank you very much for that, John. Let's move, if we can, to the Guardian of Safe Working quarterly report. Sue, please.
Hi, Sue Alcott, Medical Director. So this is the report that comes through to the board regularly, quarterly, to assure the board that we are compliant in terms of our junior doctor contract changes in 2016. This has been to the people, forgive me for not the long title, but the People Committee, I call it that in shorthand, to scrutinise already. In terms of recommendations to the board, it is to seek assurance that we're compliant, which the report says we are. Junior doctor forums continue. We've got very little vacancy in terms of our trainee posts, which is really positive news, and any vacancies that we have had in terms of out of hour on calls have been filled, which is a really important part. And then it shows that we've only had 3 exception reports, which is very in terms of benchmarking, that's in keeping with what you'd expect. So I'll leave it there.
Great, thanks, Sue. I think it's a very clear report for us, and we're invited to take assurance from that. I'm not seeing any hands going up, so it's one of these important regular reports that we get. In which case, let's move on to our next one, which is the Mortality, Surveillance and Learning from Deaths report. And Sue, it sticks with you.
Okay, thanks. So this again is learning from deaths has been a national requirement for the last 7 years. It's been in place, and again, it has reporting requirements to board, which is why the report is here. Of importance in terms of from a board perspective is to understand that again we are compliant in terms of undertaking our duties in terms of learning from deaths, so both in terms of monitoring our statistics in terms of patient deaths for varying reasons, but most importantly that the trust is learning from the deaths, because no matter if it's an expected death, there is always the philosophy is that there is always learning available, and we should take every opportunity, which I think the report does show. The report also shows about our PFDs, pulls together learning from different routes and shows that through the coroners. It shows where we've had learning from 2 patients whose deaths were viewed to have been due to problems in care. I think it's a very open and honest sharing of the learning from all the different situations that we come into in terms of with our patients. So in that sense, I'd commend it to board to be assured that we are following our requirements to learn from deaths, to share that, to show the learning across the board. There's a lot in there. I'm not going to go through it all. I think it's helpful for board members to see some of the detail, which is why I haven't cut some of that detail down, if I'm honest. So, for example, about zero suicide and the family liaison workers, just so that you can see the context, but I'll stop and take any questions.
Great, thanks, Sue. I do think it is helpful, and just to pick up that the PFDs is the prevention of future deaths, which were very key pieces for us to respond to and learn from as well. So I'm not seeing any hands going up. I think your context there, Sue, about actually how we approach this is it really plays to our values about us as genuinely learning from deaths. I appreciate you pointing out that that includes learning from deaths that were kind of expected, as well as the unexpected. So let's receive that one, and we'll move to another one from you as well, Sue, please. Another quarterly report, the Security Services quarterly report.
So again, this is presented in terms of my role as Executive Director of Forensic Services, and again, this is a compliance. It's a report to demonstrate our compliance with security directions. In essence, there's 2 recommendations. One is for the board to be assured that we remain compliant with the security directions. The second is to request the board to authorise the ongoing continuation of nighttime confinement, which is due for discussion at the board after the further 3 months duration. Previously at board, colleagues have asked for a little bit more detail about nighttime confinement in terms of where patients haven't been subject to it, which is provided in the report now, so that you can see where patients haven't, why that is, and what the mitigations have been in place. And board has also asked before about how assured, or how do I provide assurance that the forensic division is, I'm trying to think of the right phrase, regularly reviewing risks, etc. And so the high risk assessment nighttime confinement compliance report on page 93 shows where the risk assessments have all been assessed to assist with that process. So it gives the board that extra assurance that that check and balance is in place. Again, I'm not going to go through the detail of the report. It's standard headings and data in terms of grounds access, drug testing, so on. The security audit we've talked about before. Plans are currently going on in terms of how the 2022 security audit will go, and that's work across all 3 high secures together. The important thing just to pull out clearly for board is that derogations that were in place from the security directions in December and January of 21 into 22 have now all ceased, so we are fully back in line in compliance with the directions. So I'll stop at that point.
Great, thanks, Sue. And really good just to make those connections to previous board conversations as well for us. It is a standard, though important, report for us. Again, I'll just pause to see if there are any hands going up. In which case, if I could just ask colleagues to indicate we do need to authorise the continuation of night confinement and under the appropriate directions for a further 3 months. So if I could ask you to give me an indication on that, please. It is important that we do this as a part of our board responsibility. Great, thank you very much. In which case, let's move on then to item 19, the Board Assurance Framework, or BAF as we call it. John, I think you're going to steer us through this.
Yeah, thanks, Paul. So yeah, me for the same reasons as the previous paper today. So just to, again, take the report as read. Just a couple of things to highlight on page 95, and to note the addition of a new strategic risk, SR7, with regard to our relatively new role as commissioner, and that's well described in the report. To note, risk appetite levels being reviewed, risks and tolerances have also been reviewed, been no changes to those. The key point, just to bring the board's attention to today, is the bullet point on page 95 around assurance levels. This relates to a discussion from the board committee with regard to not being able to conclude with regard to an assurance rating on our financial improvement programme. So if you flip to page 115, that's described in more detail. Not necessarily for a long conversation, because I know the committee went into this in a lot of detail, but it's just an important point for us in terms of at the moment we have an inconclusive position with regard to this assurance. From a technical perspective, that's not a great place to be. Ideally, it should be one or the other. I'll ask in a minute whether Alison and or Nigel want to comment. From my perspective, I'd be content, even if we can't describe exactly what's missing, to err on the side of caution and to go for a red if we don't feel we are assured and we can take more time to think it through. But just purely from a technical perspective, sitting on the fence, I think as a board we just need to move on that. So that's the main point just to bring people's attention to today, Paul. Thank you.
Thanks, John. And you did pick up something that I had a little puzzlement on as well. Nigel, do you just want to give us a perspective on that, and then maybe hear from Alison, and then see if we need to test that further with colleagues? Nigel.
Yeah, thanks, Paul. I think we're all joined up on this. John, it's beautifully presented, and as a standing director of corporate assurance, it's impressive, actually. Your grip of these governance matters is better than mine. I think, the amber rating reflects probably my confusion more than anybody else, actually. I hadn't understood, in terms of the terminology in the trust, inconclusive assurance I'd taken to mean some kind of partial assurance, which meant there's some degree of assurance, but it's not what we would like. I never meant it to infer that we were undecided. But I do agree with John's summary of it, really. It should either be we are assured or we're not. And in this case, referencing the previous discussion on the financial improvement programme, I think it's probably fair to say, well, it's fair to say, that we're not yet assured. So it should be read. So I agree, but I apologise for any confusion created by my misunderstanding.
No, I think actually, Nigel, it led to us actually being able to do a little bit of proper thinking around it, which is perhaps a helpful unintended consequence on it. Alison, did you just want to add any comment? And then I'll
Yeah. Thank you, Paul. Yes, I agree with Nigel. I think the conversation at Finance and Planning Committee was a good conversation and a good challenge. I think I agree that given that our non-exec directors don't feel assured, that should be, the assurance rating should be read, and I think we need to do quite a lot further work at Finance and Planning Committee on giving that assurance, and probably outside of that committee to make sure that we're all aligned in terms of the BAF. But I agree that at this point that should go to a red and unassured at this point. Thank you.
Thanks. Stephen, do you want to comment?
Yes, Paul. I mean, my comment is a broader one. So Stephen Jackson, Non-Executive Director, and speaking in this very moment as Chair of Audit Committee. I just want to say that you know, the quality of the report that we've received, and indeed the conversation that's just been held, do show that the Trust's risk management process is indeed working and working well, and you can see the way in which different risks have been discussed in committees and at the risk committee shows that we are seeking assurance in appropriate manner. So I think from that perspective we can take a good deal of assurance from John's paper.
Thanks, Stephen. So we are asked to give approval to the board assurance framework and significant risks report. Could I just first off get an indication for colleagues if you agree with this proposal that John put, that we actually as a board move that inconclusive rating to a red? And I think we can note that there are actions in place that the committee has put in place and that Alison has got in place. So if I could just take that first of all. So thank you, getting agreement on that. And then with that amendment then, could we agree the board assurance framework as presented? That's great. Thank you very much. And yeah, good reflection, Stephen, about the kind of the implication around our overall governance of risk there. That was helpful. So let's move on, if we can, then, from the reports from subcommittees. As ever, colleagues, take them as read. If you want to highlight anything that's being flagged for escalation to the board, they'll obviously do that. Trevor, could we start with you from the Strategy Committee, please?
Thank you, Paul. Yeah, Trevor Orman, Non-Exec Director and Chair of Strategy. We held our committee meeting on the 7th of the 27th, and the areas that we covered out on our agenda were structured around our actual strategy. So for our performance, our care, working together, and our people. And we've deliberately structured the agenda to make sure we're very clear that the strategic intent of the Trust is aligned to what we're reviewing. So it was a very worthwhile meeting. We had no points of escalation specifically to the board. The one agenda item that we had to sign off on was the actual Trust strategy, and that was mentioned earlier in the meeting today, Chair. So very good meeting, good attendance, good discussions. We know that we've got to hold the agenda at the right level and not overlap with any of the other committees, and we're managing to do that. So I was very encouraged by the direction of travel that the Strategy Committee is taking at this stage. That's it for me, Chair. Thank you.
Thanks, Trevor. And then if we could move to Sue, please, for the report from People, Culture, Equality and Inclusion.
Thank you, Chair. Sue Nixon, Non-Exec Director and Chair of this committee. You can see the meeting was held on the 20th of May. We've summarised the key points, and as we've heard today, there's much more work to be done in terms of the staff survey response reports. And I think the board should be mindful that we did defer the workforce plan, which is a critical piece of work that we'd had at an earlier meeting. But as we've heard, Jen, as the new exec director, wanted to make it something that she would be leading on. So she will be doing extensive additional pieces of work to bring that to our next meeting. You can see the number of things we gave approval for, and we have mentioned earlier today about the deep dive into the absence rate. So may I encourage colleagues, if they want to look at board intel, all the detail that we were discussing is contained in there. And you will note that we did have some significant discussion on this on our BAF element, the risks related to the committee around the staff issues, and those are still outside the acceptable level. So we are pushing very strongly to get that work done. I don't think I really want to add any more, Paul, because it is there. But other than the fact that drawing this attention to the workforce health and safety update, elements of that were coming to our committee and the authors felt that they were having to report in two places. So you will see we've referred that to executive and the risk committee, because obviously there is a danger for that to fall between two stools, if you like, between two committees. So we're waiting to hear the response back from that, because we don't want to be in a difficult situation in terms of safety issues.
Thanks very much, Sue. Again, I'm not seeing anybody indicating needing to come in, so let's move to the Finance and Planning Committee highlights. Nigel, please.
Thank you, Paul. I think I can be very brief, actually. The main concern that I was going to highlight to the board has already been well covered, I think, in terms of the financial improvement plan. I don't want to say any more about that. And I think the rest is self-explanatory, so I'm obviously happy to take questions, but I'll leave it at that.
Great, thanks, Nigel. Yeah, I think we've had a good bite at some of this, some of the work that you'd been covering off already. So if we can move then to the highlight report from an extraordinary Quality and Mental Health Legislation Committee, Carolyn.
Thank you. The report is as read, Chairman. The meeting was convened to review the first draft of the annual quality report. Pleased to report that it's all on progress, on target for publication in June, and we will be reviewing it again at our next meeting in terms of its final draft. Great, that's great. Thank you very much, Carolyn. So I want to move us on to item 24, which is something that's new. So I just wanted to spend a minute introducing this. As a board, we've talked about the fact that we start our board meetings with those patient carer focused, sometimes staff focused inputs like we did today with Neil, which was really, really helpful. But what we also want to do is to see, just to be able to take a pause and in public recognise and showcase services. And the way we're doing this, and this is the very first time we're doing it, so it's just to put that out there. But what we want to do is use our board meetings to provide a video showcase of a service at the end of each board. It's not an item that we're then going to discuss or comment on. It's really just for us to be able to see and just hear a little from services. And today's service, starting us off, and Becky did give a little flag to it earlier on, is the Urgent Community Response Service. So I'm hoping, Roshane, that you're able to take us to a video link and give us a showing of this short video. It's 4 or 5 minutes. So let's see if Roshane can work her magic.
So I work for the Urgent Community Response team, responding to people and families, carers in crisis. This service is a 2-hour response service that goes out and does holistic assessments on patients, families and carers to avoid hospital admissions and to provide independence at home for the patient.
So we respond to patients who have low-level infections where they don't need hospital treatment for that infection. However, it is impacting on their ability to manage their daily activities. So we would go in and support those patients to remain safe within their own home. We respond to palliative patients who have already made the decision that their
chosen place of death is home, but they've had a sudden deterioration, and we respond again within that 2 hours.
They can come from emergency department, we get referrals from GPs, we get referrals from district nurses, we can get referrals from EMAS. A challenge that I found sometimes is when it's a poor discharge. So when a patient's been sent home either with no, they're immobile, so they've had an injury, they've been sent home, they can't mobilise, they've had no package of care, they've got no equipment there, and then we go in and this patient is in full-on crisis because they have been discharged from hospital with nothing.
Most proud of, obviously, the service that we offer is a really positive service, and we are looking to promote that independence and keep people at home, which is a massive part of what people want. I think we also look holistically, not just at the patient, but also looking at their relatives, the family as a whole, and I think that's something that we have the time to do, which is a privilege, really.
Yeah, so while the urgent response services are set up across the entire organisation to respond to the national mandate, in Mid-Nots we perform a slightly different function in that we take all the referrals for urgent response for the whole county, minus Nottingham City. So we are the hub for urgent response in the organisation. So all the calls that come through for urgent response for Bassett Law, for Mid-Nots, and for South Notts are fielded by my team. That's there for 12 hours a day, 7 days a week, every single day. So it's quite a lot of responsibility, and it takes quite a lot of organisation and being able to switch from task to task while they're doing that. And also the staff respond as well. So they go out and actually fulfil those referrals when in the Mid-Nots area, and the staff rotate around those roles in their role. But we also have a hospital at home team that sits alongside that. So that's led by 4 ACPs, advanced clinical practitioners, and they really caseload hold and look at the patients from a more sort of less immediate response and keeping the patient at home in the short term. And they're overseen by a geriatrician who works at Kingsmill as well.
I think as a team, we're led by Emma to there's no wrong door approach, which is great because we'll make sure that people are seen when they need to be seen and they don't slip through the net. I think that's one very good aspect of our team, is that we're happy to help no matter what, and we're as a team very good at highlighting who needs seeing by who.
Part of it is yes, it's to do with the urgent responses, it's responding within 2 hours and doing that clinical face-to-face response, but it's also being a hub and a resource for community services at large, so that and a portal into community services, because it's a complex world. It's community healthcare is complex, and we're seen as the way in, the front door of that, which is great.
Fantastic. I think this is something I know our comms media colleagues are going to be progressing more, just to give us those little insights into key services for us. So really pleased that we can introduce this as part of our board and just hear from some of our staff directly about what it is that they're really proud of as we go through. So let's just move finally, if we can, colleagues. I've got no urgent business that's been notified to me, and I'd like just to get a couple of minutes of reflections, please, on how today's meeting has been, particularly in the context of our values. If anybody would like to give me a comment or two. Carolyn, you've appeared on my screen, so I think I'm going to come to you.
Thank you. Yeah, Paul, I'd just like to go back to our patient story right at the start of the board meeting, and I felt it was a very passionate story. There was a need for us to do something really constructive about improving our staff's confidence to work with relatives of patients with severe mental health issues. So I just want to remind ourselves really that we need to go back to that and do something about that in a really constructive way.
Great, thanks, Carolyn. I think that's a helpful reminder for us. Who else would like to come in? Nigel, I think you're appeared on the screen, so let me hear from you, Nigel, please.
Well, I only put the camera on because I thought everybody else was putting it on. But I will give you a comment, Paul. I think it was a very good meeting. I enjoyed, in quotes, the carer story. It was a bit discomforting, wasn't it, to hear someone speak like that? But we need to do that. I think we need to hear it. And I think overall, I thought it was it's given me a feeling that the issues are being discussed and we are finding out where the pinch points are, and there doesn't seem to be any holding back of, you know, talking about problems. So I'm quite happy with it, actually. And in the time available, I think we focused on the right issues and some good quality discussion.
Great, thank you. Sue, please, Sue Nixon.
Yeah, thanks, Paul. Yes, I would agree with Nigel. I think we've had an open and honest debate among a number of the items, and we've said some of these things aren't right. So I think that's important. What I did actually want to say was to build on Carolyn's comment with regard to the patient story. At a lot of our board meetings, we've either had a patient story or a staff story. We have given a commitment today that we want to understand and build and address some of those issues. But the question I'm asking myself is that we've had some patient stories before, or staff stories. We've said we're going to be committed to making those changes, but I'm not sure we've checked back, say in 6 months' time, to see actually what has happened and have those changes taken place. So I'm just asking myself as a member of the board, should we make sure we do that double check and rehearse that there is some follow-up? Okay, we heard this, and what did we do as a result of that, and have things changed? So I just put that out there for us to think about.
I think it's a really good challenge, Sue. And John, perhaps we could ask you to take back to the execs consideration of maybe a couple of times a year coming back to us to say, here's the so what and the learning from those inputs from patients and staff, or perhaps just consider the best way of bringing that back to us. I do think it's a good point. So thanks. Great, Stephen.
Yeah, I thought it's been a really good board meeting. Like the others, I thought the carer at the beginning was outstanding, and you know his bravery and speaking out was fantastic. So I agree with what everyone else has said about that. I thought the meeting has reflected our culture and values in a number of places, but it's also done other things. I think we've focused on key issues, you know, particularly as I would say, wouldn't I, you know, our financial challenge that we've got. And we've also had assurance and confidence in the processes and systems that we put in place. So I think all round we've addressed the right issues, and we've done it in a good way and in a prompt way as well, because we'll finish on time more or less.
Thanks very much, Stephen. I think the final thing I just want to say is just to reflect alongside those very positive pieces. I do think just recognising that there's that continued piece of work around getting our performance reporting right, and I think that acknowledgement that, you know, we just need to get our executive colleagues to really think through what's the best way of making use of the committees as well as the board is a really important piece. I think that's a key piece of learning. So just before I close this meeting, just to say that we're actually going to take a slightly longer lunch break than I usually let you. So we're going to restart at 1 o'clock. Those of us who are in Duncan Macmillan House, our headquarters, we've got an opportunity to go and join some of our volunteers who have been celebrating Volunteers Week and are in part of the building. And luckily, now that the restrictions have eased somewhat, it means those of us who are in the building are able to go and spend a little bit of time meeting with and listening to, talking with some of our volunteers. So that's why we're taking a little longer. Colleagues, if we could restart for our part 2 confidential board at 1 o'clock through the other link. And thanks very much for your contributions so far today. Thanks very much.